Now we get to my favorite topic, which is opioids. And I have to tell you that I'm neither a therapeutic nihilist or an overprescriber. I think that there is a balanced approach to opioids, and I'm going to try and present that. But I am going to give the bias really, I'm going to bring up some of the problems with opioids, put it that way. If you're going to prescribe opioids, they ought to be prescribed as a clinical trial, especially with new chronic pain. Now, I know a lot of you have inherited patients who come in on high-dose opioids. That's a whole different project, if you will. But if you've got somebody whose pain is going on for longer than 3 months and you think it's going to be chronic, and you decide that opiates is the drug that you want to use, do it as a trial. What will you monitor in this clinical trial? Well, assess function. Is life better or worse on these medications? If it's better, that means I can participate in the soccer games with my kids, and I do get out of bed, I can work, my alertness is not affected, and I feel overall my life is going better, and you get some collateral information that supports that, we're in good shape. I think what happens more often than not, because of the nature of these drugs, is that that happens for a period of time, and then what? They come back in next month, and what do they say?
It's not working anymore.
Right. So what do? Double the dose, because they're tolerant. So if we double the dose, what happens the next month? And what I ask is that we have this projective look at where is this person going to be 3 months, 6 months, a year down the line when I start the medication. And I have a conversation with them, and I have a strategy to exit this plan, and that they're participating in that plan. Now, if they're drug seeking and they're manufacturing symptoms and they want drugs and nothing else, obviously you're going to be in a different situation, but I don't think that's most of our patients. I think most of our patients develop pain and they have an unrealistic expectation that we can make it go away and that these drugs are benign. I can't tell you how many people come into treatment who tell me, I wish my doctor had told me what was going to happen with these drugs, meaning tolerance, decreased function, and physical dependence. I can't stop. I didn't know that before I started. So I think it's everybody's job who's prescribing these medications to give due information to the patient that they're prescribing to. There's a lot of problems with opioids. I probably don't have to preach to the choir, but I'll tell you, side effects are significant. They're dirty drugs. There are opiate receptors all over the body, in the gut, so there's constipation. There's cognitive effects. There are immune effects, so that people's T cell counts go down and CD8s go up. There are hormonal effects, decrease in estrogen, bone density problems with men and women, decreased testosterone. So they're not benign drugs. And of course, they cause respiratory depression. The good news is that we get tolerant to that pretty quickly. So it's hard to overdose and die unless you mix sedatives into the picture, which is another whole issue. Tolerance and physical dependence. Do people have patients in their practice who don't have tolerance physical dependence? Well, I'm surprised, because I would expect half of you to say, yeah, there are some people that stay on a steady dose and do okay. So, and I think that happens. I don't know why some people do, some people don't. It's probably genetic predisposition. But the vast majority of people become tolerant. The vast majority of people can't stop without assistance medically. Yes, sir?
How long does it take to become tolerant, to physically dependent on it?
About a month. About a month. So if you're embarking on a course and you've had somebody on an opiate for about 30 days, you can expect that they're going to have some mental withdrawal. The longer they're on, the more likely it's going to happen and the more intense. Yeah. And people's function diminishes on these drugs. These are the people that take their opioids and fall asleep in their soup. They're not getting up and going. They're not working. They're not joyous. They're not, they're not living. Their system is dulled by this drug because these kill pain, physical and emotional. They're working in the limbic system just along with the cognitive areas of the brain and the analgesic areas of the brain. We know that certain people perceive emotional pain as physical pain. We describe those people who have this suffering. So they can't differentiate anxiety from back pain. And I can tell you, my back ratchets up when I'm anxious. When I look around the room, people are going, what the hell is he talking about? My back hurts worse. So, buck up everybody, pay attention. So it's really important, they've defined a term, chemical coping. You know, these are people that take a couple of Vicodin and their marriage gets better. Now, is that appropriate use of pain medications? I don't think so. And then last is, how many people know about opiate-induced hyperalgesia? Reddit? So about half. Please understand that in a percentage of people, opioids cause more pain. They do it biophysiologically. There's elevation of glutamate and NMDA. There's activation of glial cells that are pretty inactive unless opioids are present. Mast cells are activated in people on chronic opioids, and not everybody gets this, but in some people, there is a maximum dose, optimal dose of opioids, and that's it. And I can't tell you what it is. It could be 60 milligrams of hydrocodone a day. I can guarantee it's not 120 milligrams of morphine equivalent a day. When we're getting over 120, over 100, we're getting into